Hello and welcome again to the continuation of the 5th Pancreas Cancer Academy organized by the Central European Cooperative Oncology Group. I want to thank the faculty which participates in this 5th Pancreas Cancer Academy. I want to thank Servier for supporting it and thank Gerald Prager for organizing the faculty and coordinating the news that are being brought to you. I wish you very interesting hours with the continuation of the Pancreas Cancer Academy, and I do hope that we will see each other in person in the very near future to celebrate the 6th Pancreas Cancer Academy. Thank you very much and all the best.
Hello, ladies and gentlemen. My name is Gerald Prager. It's a pleasure for me today to somehow moderate this very important session on quality of life. I'm very happy to introduce you Francesca Beste. She is a patient who can tell us how important is quality of life in terms of quality of life during treatment. What are the treatment aims? Probably I can bring in what is the doctor's perspective and what does patients expect. What is quality of life? Let me somehow define the term quality of life. It is defined as the state of well-being, which is a composite of two components. Their ability to perform everyday activities that reflect physical, psychological, and social well-being, and also the patient satisfaction with levels of functioning and control of the disease. The smaller the gap between the patient's expectations and the achievements are, the higher the quality of life. So we, from the medical perspective, we try to evaluate patient-reported outcomes as a reflection of quality of life. I think this is, in terms of clinical trials, extremely important because when we perform clinical trials with new drugs or new drug combinations, patient-reported outcomes, so the quality of life of our patients assessed by the patients, is in fact the only readout which is not biased or cannot be biased by the investigators, because the patients themselves, they're filing the forms of the quality of life assessments. But this is part of clinical trials. But today we want to discuss the experience of patients and how they experience the quality of life, what we can improve in terms of quality of life during treatments, what are the expectations from the patient side, and how we as doctors or healthcare providers can improve the outcome in terms of the quality of life of our patients. Also happy to introduce Ellie Stampt. She's also a patient advocate. Ellie Stampt was also a cancer patient, pancreatic cancer patients. Thanks God, already almost 15 years or 14 years ago. And she also went through treatment, and she can also discuss her experience on the quality of life. And today, especially with the perspective of the pandemic, we want to give a special perspective how the pandemic is affecting or can potentially affect the surveillance, the follow-up, the cancer survivorship, as well as patients undergoing treatment, how the pandemic might affect the quality of life. So enough said from my side. I would like to start now with Ellie Stampt. Ellie, do you want to give your a short introduction before then Francesca Beste will discuss her experience?
Hello, thank you. And you gave me a fantastic introduction anyway. Yes, it's 14 years this year, that I was diagnosed with pancreatic cancer. Luckily, I was diagnosed early in time for surgery to be a possibility. I had a distal pancreatectomy and splenectomy, and that followed on with combination chemotherapy, and that included gemcitabine and cisplatin. I've got my own experience, but of obviously sort of 13, 14 years ago, of the what it's like for quality of life for patients and how that's measured. I'm hoping that we'll see that things have moved on a little bit since my time, and certainly I run an organisation in the UK called Pancreatic Cancer Action, and we focus on supporting patients and also to campaign for earlier diagnosis of pancreatic cancer. So got some experience of other people along the years from what they've been telling us, and particularly with the COVID-19 situation, which we've been monitoring very closely.
Thank you very much. Francesca Besse, you want to say some introductive words to this? Sure.
Yep, my experience this role started in November 2017, more than 3 years ago. So I'm very happy now that that's over 3 years. Started chemotherapy. I've been in chemotherapy for over 3 years, it has been a very interesting experience for myself, for my life, and in getting to know a community I knew about and a world I knew nothing about. And it started very focused on myself, on my health problems. But being a very curious person, I just started looking around and understanding what was around me and how other people coped. And so I also got in touch with I just bumped in Codice Viola, which is a patient that's in Italy for pancreatic cancer, and I started interacting with them and getting to know other patients and understanding their needs and inventing activities that could help us get through this period together. And let's say this is what I've been doing for over 3 years, and I think it has been a sufficient for now. Since should be told to others. It shouldn't be kept inside our association and linked with other associations and other parts of the world, including obviously the doctor and oncologists. So I think that's enough as an introduction.
Yeah, so when we as doctors discuss what is the most important aim, I think it's out of doubt that we want to improve the prognosis of our patients when we do chemotherapy or surgery. I mean, this is out of discussion. But then we very often discuss quality of life. But on my side of the table, quality of life probably is different discussed than on the patient side. So what defines for you quality of life during, let's say, a systemic anti-treatment?
Well, first of all, let me tell you that in the past month, thinking of what I should say today, all of a sudden I remembered that a few months ago, like 3 or 4 months ago, I started a sort of exercise, a game. I wrote an email to my oncologist. I mean, he's become a friend of mine by now, and putting in one of his friends who's a surgeon. And I started outlining a sort of utopia. What would be the ideal place, hospital, or let's say place where to pancreatic cancer to where people could come and find help and find information and then be operated, do chemotherapy. But it was a game, and it was we started. It was sort of a farmhouse in the south of Italy. It was very concrete. It was nothing theoretic. It was what kind of a place, what it should look like, what it should have in, what should be its rules, and it started with my email, and they found it because obviously it was utopia. So they started answering themselves, and so I went back to look at what we wrote to each other. It lasted about a month, not every day, but when we had something to put in, something that we realized that was needed in this ideal place, we just answered. Like the last one was, I'd like a very good lawnmower, just to tell you at what point we had reached. It was very interesting to see the difference between what I put in and what they put in, because in things from my patient point of view, they put things from their professional point of view. Some overlapped in quality, but obviously there was something they would never have thought about. Okay, so obviously I'm not going to describe all our dream, because I'm afraid someone will steal it from us and put it up in another country. And so, but I think that starting from the very beginning is actually the very beginning is the difficult part, because you end up with doctors, you have no idea what this world is like. The first thing you think when you have cancer is, oh God, cancer, I'm going to die, or oh God, I have to do chemotherapy, something that's terrible, that's going to destroy my life, because chemotherapy, we all have in mind these old American films of people dying, or terrible idea that hasn't been updated in any way, geography. So the idea we have when we are told we have cancer, that it's pancreatic cancer, is, oh God, you're going to die for sure within a few months. So you go to your family doctor. If you're lucky, you go to a good family doctor. I did. I was lucky in everything in this part of my life. Everything. If you had to have cancer, then I'm the luckiest person that could have one, because I had a good family doctor. I have doctors in my enlarged family. They told me where I should go. I could choose. I had money enough to go where the good doctors were. But all this is not put up in the standard offer of response to cancer patients. You just have to suppose it's all there. Okay. So let's suppose that it's all there, that you go to a good family doctor who understands that you might have a problem, give you all the checkups, you know where to do them in quickly. You don't have to go around anxious, because this is quality of life. If you don't know what to do and where to do it, and if you don't have the possibility to do things quickly, you just get anxious, and obviously it's even worse for you. You feel worse. Your health gets worse and worse, because it's not that you have a few things to do. You just go and do them, and you get your answers, and everything's fine. That's not how it works. It just works that all of a sudden you don't just have cancer. You have to cope with loads of problems linked to this cancer stuff. So you're lucky if you're born in a context, in a social context where there are information, someone gives them to you, where you have the money to go to the good places. Even if you have a national health system that covers most of the expenses, but if the good doctors are on the other side of the country, you have to take a train, go pay a hotel, and all this. Okay, that's the first part that is completely ignored, obviously by doctors, because the oncologists find this already done. Once you get to the good oncologist, all this is already solved. But the patient itself has to solve it, and it's not easy. So let's have this done. Then you find an oncologist in a multidisciplinary center that is good in pancreatic cancer, and that's very difficult. I don't know in other countries. In Italy, it's not easy to do that. if you're someone curious, you get on the social media, you go, you bump into the right channels, and quite quickly you find out which are the 4 or 5 good places you could go to, and then you visit them and try to understand how to proceed with your cures. And that's when, let's say you start chemotherapy. Most of the cases, obviously, in some cases you are lucky and you get operated, and you get correctly operated in the good centers because they understand that you should, and not because they like operating how or they don't know much about it. You start chemotherapy, and the good centers give you, at least here, they give you a list of possible side effects, a number you can call if you're in difficulty, some solutions to the single side effects. That's more or less what you get. So my experience with other patients, I'm lucky, as I said, I've had no side effects to any of the chemotherapies I've been doing for 3 years, and I've done many different ones in 3.5 years. So I didn't have most of these problems, but I help lots of patients who, first of all, are scared of the possible side effects. So they start feeling the symptoms even if they don't have them, just before chemotherapy. And then obviously they concentrate all their attention on every single symptom, because if you're so afraid and you're told they're so terrible, what you do is you just wait for them. And you start asking, what should I do? What can I do? And you have, for example, on Facebook groups, you have tens and tens of other patients saying, oh, you should do that. I just take this medicine. And so the patient has just doesn't have sort of correct indications from one place or one person saying, if this happens, do that. If this happens, call me and we can see how to move from here onwards. And this can go on for months, obviously. Quality of life in this period means having someone, but someone you can trust, and someone who can give you the correct information, telling you how to move, even day by day. I mean, it sounds absurd, but that's the point. If you wake up in the morning and you have a rash and you don't know what it is, you don't know what to do, and you're feeling terrible, and you go to the pharmacy and they give you something for that day, and the following day you wake up and you have another symptom and you don't know what to do. You ask someone else and they tell you, hey, take this medicine, it helped me. And after a week, you're all day in bed because you're tired, and you start getting worried. It's not just being tired. Tired is, who cares if you're tired? You rest if you're tired in any other context. But in this context, if you're tired, you start thinking, oh God, maybe I'm dying. Why am I so tired? And you start thinking all the worse, and you have no one who can help you sort of understand that you should just give yourself the time to get over it. It happens. It can be not terrible. Hospitals, from my experience, I've changed to, don't have, well, they don't even have a real good call center you can call for medical things, for problems with your chemotherapy itself, unless you're in a trial. You just go there every 2 weeks for your chemotherapy and nothing much else. For side effects, they have practically nothing. From this point of view, Patients Association can be a great help. What I learned to do was put up a group. It's a WhatsApp group with 45 patients in it. Selected patients, not just any patients, because it has to help in a community context, and patients from all different moments. I mean, there's me after 3.5 years. There's someone who started chemotherapy 2 months ago, someone who's been operated 3 years ago and is undergoing nothing, it's just there. This group of people help each other. It's sort of a self-help group, and it's very important because it helps you understand that there's life in this period of chemotherapy. And the problem that most patients forget, they forget that there's life while you're doing chemotherapy. For most patients, the moment they enter this world, they start doing chemotherapy, the pieces of life, the days between one therapy and the other, are non-existent. They're just waiting moments from one day to the other 2 weeks. So it's a fortnight of waiting to do another chemotherapy, and then waiting for the TC, waiting for the results of that chemotherapy. So it's months, first weeks, then months, and then years of waiting, of interrupting your life, waiting to get better, waiting for nothing. You're just wasting your time. So we have been teaching each other, because it's something you learn one from the other, that there's life in chemotherapy, there's life while you get cured. There's life going out for a walk together. I know it's bad to say, and I shouldn't say it in this today that we're talking about quality of life and COVID, but one of my best years has been last year, and it was best also for COVID, because everyone was in lockdown and they were stuck in, and I was not, because for health reasons you can move, and I live in Rome, and my hospital is in Milan, so I could go for Milan driving myself every month or every 2 months for my therapy, and then I traveled a lot, because I started liking this fact of going around. Very few people around. This last summer, when we could move, I moved because I had learned that I could move and I could live for a cure. And if you can move to get cured, you can move for holidays. So I went around Italy with my car and meeting other patients as well, and walking with them around and spending a day with them. I went to Sicily and met some patients there. And they were living, they were not waiting for anything. They were living their life, because we don't have to wait. And it's important that they understand that this period is not a waiting period, it's a living period. All this, though, should not be made possible only thanks to volunteer work of associations. I think that hospitals should put up some structures where you can call, where you can either call or meet other patients, or other persons who can show you that you don't have to stop anything. To tell you how much people stop, a few months ago, I was called by a woman whose mother was, and she was very worried for her mother, because her mother going out. She wasn't moving from home anymore for the past month and a half, and she would just go out with her, driving hospital for chemotherapy. So I asked her, when did this immobility start? When this one had this problem started? When had she stopped going out, walking around the neighborhood and buying groceries. She thought about it and she said, well, the day after she was diagnosed cancer. And I said, oh, so do you understand what happened? She was told she had cancer, she stopped living. She started feeling bad, physically bad. She felt sick, and she had stopped asking her body to do anything. And so I said, don't treat her as if she was sick. Treat her as you had treated her until the day before, because it's not that the day after anything had changed physically in her. And so she understood, and that was one of the points that that I've been reminding other patients of. Last year in June, we organized a 4-day trekking in Tuscany for pancreatic. Obviously, it was a slow trekking, as trekkings should be, for patients and their caregivers. And it was a wonderful experience. And it was just after the lockdown was suspended. We were supposed to go in April, but obviously we couldn't, so we postponed it until the first good weekend, and we went, and it was a wonderful experience. And people could not imagine that patients undergoing chemotherapy, we were all under chemotherapy. Our oncologist moved our therapies so that we shouldn't go the day after our chemo, but the weekend before our chemos. And we spent 4.5 days walking and joking and having fun and living and breathing air, and it was fun, and we'd like to repeat this experience. This you can also do if you have an oncologist who looks at you not only as someone to treat medically, but careful about the aspects of you as a person, not only as a sort of a patient. It's not easy because in most hospitals in Italy, what happens is that the first time you go, you meet a doctor, and every time you might meet that doctor or you might not. So you have a rotation, and who know nothing of you and have no way to understand if there's an improvement or not in your quality of life, unless you explicitly explain your single symptoms. But sometimes for you, the single symptoms are not relevant. I mean, sometimes they are, of course, if they're so bad that you just cannot continue your normal life. But, sometimes the questions about can you continue your normal life is, can you continue cooking for your family? Which I find a very stupid question. Or can you continue doing the things that you were doing before at home? I feel it should be more. Can you wake up in the morning and feel like getting out of bed and going out for a walk, and outlining projects for the day and the following week, and meet friends, and those are the things that make you understand if you have a good quality of life. But I think one of the major points that help you have a good quality of life, this I'm learning now after 3.5 years, although I had sort of understood it all the way, since I have never had pain in these 3.5 years, just very minor pain. But I understood that the difference between me and people who had pain was this, that if you have pain, there's nothing that can relieve you from thinking moment by moment that you're sick, and that there's nothing more important in your life than the fact that you have cancer. I feel the second thing after meeting the oncologist, that one should receive is receive all the support care that you can get from that hospital, from the nutritionist, psychologist, diabetologist, and pain therapy. If you have pain, you can't do anything else. Not everything else loses importance. You can put up with it for a day, 2 days, 3 days. After 4 days, everything else starts losing importance. But if you meet all these palliative care
I have
person.
Hello, Francesca. Thank
Yeah.
you so much.
Yes.
I very much appreciate that you give us your insights and your experience. It's really great, wonderful. In respect of time, I would like also Ali now to discuss a little bit her impression and perspective, how the pandemic is affecting those important things which Francesca highlighted. So that you need to travel to centers, find your experts, share your experience with other patients. I mean, Francesca probably had found some good ways in the time where the lockdown was suspended for some months, to find some ways to connect to other patients. But what is your perspective? How much at the moment, as the pandemic seems not to have an end, what is your suggestion? Should we support much more what we're doing right now to connect via the internet, via teleconferences? So would this support also the patient advocacy groups, or what is your perspective? Should we
Yeah,
also,
well,
from the medical point of view, provide much more telemedicine services, that traveling in those countries or those times when it's not possible can be suspended?
Yes, it's been a very difficult time for patients throughout the pandemic, and various different forms of lockdown, of which we are in one here at the UK right now. We have found that patients have found it difficult to access their healthcare providers. I think with the lockdown, and we have in the UK a shielding system. So if you have a disease like cancer, or are clinically extremely vulnerable to COVID-19, then you've been asked to sort of stay at home. And a lot of the things that Francesca was talking about in terms of going out and talking to other people and networking just haven't been possible in the same ways that they would have been pre-pandemic. And there's a lot of people who are not going through cancer treatment or pancreatic cancer treatment who are feeling isolation and loneliness and anxiety. And you just put on top the anxiety around having pancreatic cancer, anxiety around the side effects, as Francesca so rightly said. You know, if you've got pain, you are less able to have good quality of life. But if the psychological support is so key in this, and I think from experience, outside of clinical trials, the patient-reported outcomes are not really measured that well, and they really should be. And I don't think that is necessarily due to the pandemic. I just think that it is something that hasn't had a huge importance until fairly recently amongst some of the medical professionals. And but I think with technology, we can definitely connect with our healthcare providers, and we can. I think things like Zoom and Teams and all the other platforms that people use to connect with one another, we're all getting quite familiar with this. But one thing that does concern me, though, and talking to patients and their families, is that our patient cohort, we've got a median age of 72. And then, therefore, not everybody is able to access these technologies or understand it. And my mother-in-law is 85, and she doesn't have pancreatic cancer, but just to get her connected with the family through this pandemic has been quite tricky. So I think we need to make sure that, as Francesca said, that patients are connected with organisations such as ours, patient advocacy groups, where we have got information that is peer and lay reviewed, that it's correct information, because the problem is people may well be going to the internet to try and find solutions for things, and that's not always the best idea, because there's a lot of bad information on the internet. But I think with regard to quality of life, that treatment shouldn't stop you from functioning as a patient. We should be able to have coping mechanisms for some of these side effects or symptoms of the disease itself. Pancreatic cancer is very complex, as we know, and it produces problems with digestion and also with glycemic control, etc. So there are added things in the mix that can actually affect the quality of your life. But I think the psychological support is not there even without a pandemic, and we really need to have somewhere where patients can go and get support, because pancreatic cancer does have a huge impact on people's well-being, and there's not always somewhere that they can go to, and certainly our clinics here in the UK, our sort of outreach workers who are clinical nurse specialists, they are so busy because there isn't enough of them. So whilst you'd have that point of contact, and whether that's over the telephone or by video call, they just don't have the time, and patients are finding that it's taking a while for them to get back to the patient, and that causes extra stress and anxiety too.
So it would need more patient or oncology navigators who could navigate the patients through everyday's problem, adverse events, how to go to what doctors to contact, and so on, right? Is there a big need
Absolutely.
for such kind of patients navigators, right?
Oh, most definitely, and you'd need somebody to be that point of reference, somebody who is medically trained, who understands the disease and understands the healthcare system, and knows what patients should be receiving in terms of treatment or support. And if you've got that key contact, then it does make life a lot easier. And oncologists and surgeons, I mean, they're all terrifically busy. They have a backlog of patients right now because of the lockdowns, and I wouldn't expect them to have to navigate patients through all of this. But I think we've got to think about what questions are actually asked of the patients when they're going in for these consultations. And I know that from personal experience, the focus was mainly on physical symptoms. And I had similar questions about was I still able to cook the supper for my family, and I had two boys who were at school at the time, and that's an important part of life, but it wasn't really very helpful in determining how good the quality of my life was at the time. And I think that the patients need to be consulted more in terms of what questions should be asked when they're reviewing quality of life, and just to make sure that we are being asked the right questions, because the wrong questions are not going to inform the healthcare professionals in terms of how that patient is faring.
And another big problem throughout the pandemic is that in many hospitals, so also in Austria, visitors for patients, for inpatients treated as patients treated as inpatients, were suspended, so we're not allowed. There's a lot of isolation of the patients in the hospitals, and I think this is a big burden, especially for cancer patients, especially in the palliative setting when they cannot see their relatives and friends anymore. So is there the same situation in UK, or what is your experience on visitors allowed for oncology patients?
Yes, I've actually heard some really distressing stories of people who are experiencing end-of-life care in either a hospital or a hospice setting, and their next of kin, their closest relative, whether it be a wife or a husband or a sibling, a child or or sibling even, just cannot say goodbye. And that has just been devastating for people, and to actually have to have that conversation with your loved one over an iPad using FaceTime is I just don't imagine how that would be if that had to happen to me. And yes, we've got the situation. We've got the situation where people are going in for chemotherapy treatment. It's for the very first time, and they're scared and they don't know what to expect. But they've got no one there to hold their hand or to reassure them. And this has a huge impact on patients, and also on the people who are caring for them, because they feel frustrated that they can't support them in the way that they really want to do so. Particularly those who are hospitalized for any length of time is particularly difficult.
So can you give us at the end of today some positive perspective, as UK is the European champion in vaccination? So do you already see a positive trend now in UK?
Oh, indeed, yes. And I've already had one of my jabs, and I've got to follow up in 2 weeks. So we've been very fortunate that over half the adult population now has been vaccinated, and we are seeing that in terms of the figures, in terms of the not just the cases, but really importantly is the number of people who are hospitalised with COVID-19 and or are in intensive care units. And we, as a result of the first lockdowns, we had a massive backlog of surgical patients, particularly chemotherapy disrupted, because people didn't really understand what the risks were to that group of patients. So rightly so, didn't want to risk them coming into the hospital setting to have treatments. We've learnt a lot over the last few months, and we have had some really, really good examples of how some specialist units have actually dealt with the pandemic, how they've isolated COVID patients away from those patients that have cancer or need other have other conditions like heart disease, etc. So we've got COVID secure hospitals now, and that is something I think is going to stay with us for quite a while. That's not happened universally across the UK, but it's definitely something that we can learn from. We've all got better at using technology, and I think we can use this kind of technology for patients where it is appropriate to speed up things in the system. I'd be quite happy to discuss my scan results with you over this kind of call, because I think in the last year we've been conditioned to the way of communicating this way, but I would be very happy as long as I could see your face. But nothing beats face-to-face interaction with somebody, because I think body language is very important for both the patient to understand perhaps what the clinician might be saying, but importantly also for the clinician to perhaps pick up on how the patient may be doing as well. So things are getting better. I think we need the world to be vaccinated. It needs to be rolled out globally. And just because we seem to be sprinting ahead, that's not necessarily going to serve as a big advantage if everybody else, we're waiting on everybody else to be vaccinated. And of course, we need to make sure that the vaccinations keep up with any variations, mutations that are coming along as well. But I think I'm a lot more optimistic this time round. We're in a second lockdown, and this time round things have been very different for patients. So they've managed to get around some of the problems with endoscopy and that we had initially, and so people have been able to be diagnosed. But what is concerning me, though, is the fact that patients and the public at large are fearful of going into a medical environment. They're fearful of going into hospital. They're fearful of presenting to their family doctor if they have symptoms. And that's really concerning, because we know that our referrals for pancreatic cancer were down 80% in the first lockdown, but still haven't recovered back up to anywhere like normal levels. So we're still got people who are not presenting, and I'm really concerned that this could be a little bit of a time bomb, certainly in the short term, for survival for patients if they're not presenting in a timely manner.
Thank you so much, Ailey. Thank you very much for giving us this insights, especially also from your country perspective. Francesca, do you want to give us your expectations for the rest of 2021 for Italy? Do you also see a better situation than a year ago?
Well, yes, it is. As Ellie was saying, this time it is different. Hospitals are working better, even though there is much isolation for patients, just as Ellie was saying. I think people are getting vaccinated quite, let's say, decently quickly in Italy as well, starting old aged and patients. So I had my first job as well a week ago, as many others have. Although many are scared to do it, should I not? And they receive different answers from different sources, but they are quickly doing it. Problem is the backlog. As we were saying a year ago, we were writing as Codice Viola in our on our website in April, May. What will we expect in September? And now we're at the same point. Not much has been thought of how to get out of this in the future. All the people that haven't gone for controls, for screening, or have postponed things are still postponing in large part. So if waiting lists were long a year ago, just imagine how they will be in 6 months. And I think all this has to be thought. Solution has to be has to come out. I also think that a network of European associations should work together to do some proposals, learn from each other's best practices, and try to propose something at the European level, and not only at the national level. So I think, I mean, we could work together at this. It's difficult to find a solution because it means investing immediately in increasing and improving healthcare. One thing which seems not to have much to do, but I think in terms of improving times, as I was saying before, having a point of reference, a call center, someone to call if you have a problem. If you have to get to know it and get to know the patient, and the patient get to know that point of reference or person of reference, once the big problems come out, it takes a long time. It takes a very valid professional, someone who is, I don't know, a palliative care or a diabetologist or whatever at that point. But if all this starts at the beginning, from once the patient goes to the hospital and gets to be known, and he or she starts calling that number or asking for help or for indications and recommendations since the beginning, it's all very easy. They have all the indications of who or she is. They get to know her personally, hope if she can move, and it costs less time every time he or she calls, and it takes a lot of burden from other specialists and a lot of anxiety from the patient. He knows that if he has a problem, he knows find a solution. So most of the time he doesn't even call because he doesn't need the reassurance that there's someone to help just in case. But if all this is given at the end, when you really need to solve a big problem, then it costs time. You'll never find a good solution because it's not easy to find out in 10 minutes call or in a 1 hour visit exactly what the problem is and how to solve it. If that person just needs a therapy for pain, or if he needs a hospice. So things should be rethought a bit from the beginning. And I still think that a network like ours should be exploited better to find some best practices that we all have one from each other.
Okay, thank you so much. Now we are already at the end. I have very much enjoyed your inputs on this very important matter. I hope the audience as well, and I want to give my special thanks to both of you, Francesca Bester from Italy and Ellie Stone from UK. It was really a very important part of our Pancreas Cancer Academy, and I hope we can continue this on another occasion. I wish you a very good day, and thank you again very much. I was very, very much impressed by your inputs. Thank you very much. Have a good day. Bye-bye.
Thank you.
Thank you very
Bye.
much, and keep safe.
Bye-bye.